It is a huge, huge honor for me today to be podcast interviewing Dr. Samuel Lee, who's a DDS and a Doctor of Medical Science, a DMSc from Harvard University. Let me start with your bio, Sam. You are an amazing man. I can't even believe you're only 39. Dr. Samuel Lee has earned double doctorate degree in dentistry. He has earned Doctor of Medical Science, 4 to 5 years full-time doctoral degree from Harvard University, and Doctor of Dental Surgery, 4 years from UCLA School of Dentistry. He's a Diplomate of American Board of Oral Implantology, Implant Dentistry, and limits his dental practice in implant surgery and orthodontics. After completing his bachelor's degree in Microbiology and Molecular Genetics at UCLA, he continued his studies at UCLA School of Dentistry for his Doctor of Dental Surgery degree. While attending dental school, he has taught biochemistry for 3 years. He loves teaching and enjoys developing new technologies. As a dentist, he practiced implant dentistry and orthodontics in a private practice in Buena Park, California for 7 years. He and his family moved to Boston area to further his study at Harvard School of Dental Medicine for his specialty certificate in periodontology and to earn Doctor of Medical Science from Harvard University. Currently, he concentrates on research and development in dentistry, and he runs private practice in Burlington, Massachusetts. He has won the first place table clinic presentation award at many prestigious organizations, the 2008 American Academy of Implant Dentistry, AAID, the 2007 American Orthodontic Society, AOS, and the 2007 International Congress of Oral Implantologists, ICOI. He is an inventor of the Crestal window sinus grafting technique and owns the patent on his sinus instruments. He currently teaches internationally on his sinus techniques and TAD to specialist general dentists and dental schools. He also developed new method of dental x-ray, and he owns that patents related to this technique. He is the president of the International Academy of Dental Implantology and focuses his career on teaching and research. Sam, you're an amazing man. Just an amazing man. My God, do you ever sleep?
Oh, thank you. Thank you, Howard, for kind introduction.
And you, so what made you so interested in implant dentistry? What got you motivated to go there?
You know, to be honest, when I graduated, I wasn't even sure whether dentist was a good career. But I began working for a general dentist who has been placing implants since 1976. His name is Michael Kwan in Los Angeles.
How do you spell Michael
with him,
Kwan?
Michael Kwan, KWN.
KWN?
KWON.
KWN. Michael Kwan in California?
In California, Los Angeles, yes.
Okay.
In that practice, I learned how to do sinus lift, implant, molar surgery, and really I push my limit in terms of learning dentistry. So, you know, the best way to learn is hands-on training. And I was at the right location at the right time. Ever since then, I've been doing a lot of sinus lift, and, you know, I came up with a new technique of lifting sinus. It's called Crestal window technique. And that technique put me on the stage in many international meetings. And on average, we do about 50 seminars a year just teaching our sinus techniques.
Wow, that is amazing. So what was not working with the way you were doing sinus lifts that made you invent a whole new way to do it?
Well, first of all, we can divide the techniques into two techniques, lateral window versus Crestal approach. Summers osteotome technique, which uses mallet, is a good technique. However, it is a blind technique. And I thought, why not combine the advantage and disadvantage of both techniques and come up with a hybrid technique. So I named this technique Crestal window technique, and I'll be more than happy to show you today on my presentation how to do this technique.
You want to start there? Just go for it.
Sure. Let me pull up my screen. Are you able to see the screen?
Yes, we can see it. Maxillary sinus grafting with a beautiful, beautiful woman there.
Yes. So historically, we have two techniques available, lateral window technique versus Crestal or alveolar approach. As I mentioned before, lateral window technique is somewhat more invasive, and after the surgery, it's very common to see a lot of bruise, swelling, and pain after lateral window. In contrast, Crestal approach is preferred, and it was first started by Dr. Summers using a mallet. And this is a better approach because patient is able to function better without much swelling and pain. However, one of the biggest disadvantage of Summers approach is that it is a blind technique, and lateral approach, people don't like to do lateral approach because of this intraosseous anastomosis, a small arteriole that runs on the lateral window. And this can be a nerve-wracking experience. Therefore, many people do not prefer to do lateral window technique. As I mentioned earlier, Crestal approach, any Crestal approach out there, whether it's using hydraulic lift or balloon or Summers osteotome technique, it is a blind technique, just like driving with your eyes closed. And certainly, I don't drive with my eyes closed, and I don't think anybody does. Then I want to challenge those surgeons who are utilizing blind technique, because you are not sure whether you have perforation or not. So I do not recommend blind technique. And one of the biggest limitation is that you need to have minimum of 5 millimeter of bone height when trying to do a Crestal approach, and that is the limitation. What if you have less than 5 millimeter? And because we're adding bone as material to lift the sinus, we end up with the dome shape graft. And if you don't lift enough because of less blood supply and less support to your implant, the long-term result is not as good when compared to a lateral window. And if we are doing lateral window, it's very important to lift the window all the way to the palatal side, as you can see in my drawing. So as a young dentist, after learning all these awesome procedures, I thought, why not combine these two techniques together and come up with a hybrid technique called Crestal window technique. You're looking through occlusal view from the oral cavity, and as you can see, you have nice Schneiderian membrane visibility, and it is like opening a lateral window, except we are opening window through the crest. Therefore, I named this technique Crestal window technique. This is the only Crestal approach that is not a blind technique. All the sinus technique out there is a blind technique once again, so you don't know whether you have perforation or not. In fact, when you are doing Crestal approach, you can have three scenarios. You can have very thin sinus membrane, as you can see on your left. The color will be transparent, it's dark because sinus is dark. And the middle picture is an example of a thick sinus membrane because the color is white. It's not transparent. You cannot see through the sinus. And on the right side is example of unhealthy sinus. It looks like a granulational tissue and it's thicker than 3 millimeter in thickness. Now, if you have very thick sinus, whether you do a blind technique or water technique or balloon technique, the result will be phenomenal. You will always have a nice dome-shaped graft after the lift, and you'll be very satisfied. In contrast, when you have very thin sinus, such as on the left, you will think that blind technique doesn't work all the time because patient already present with a very thin membrane and it's very fragile and easy to tear the membrane. When you are using non-blind technique, we are able to identify what type of membrane patient is presented, and you can utilize the appropriate technique. For example, if I have a very thin sinus, then I would like to use small instruments that I develop to be able to lift the sinus And I want to verify that membrane is not torn before putting bone graft or before putting any foreign material to the sterile sinus. In contrast, when I have a thick sinus membrane, it's very easy, it's very predictable, so I don't even bother to lift the sinus. I just pack bone and insert the implant, let the implant push the sinus membrane towards the sinus. Now, most important aspect is identifying unhealthy sinus. Typically on the CT scan, this sinus shows up thicker than 3 millimeter, and it is very important to remove all the granulational tissue, and perhaps it's not a good idea to lift the sinus at this stage. It's better to abort the procedure and come back until the sinus becomes healthier. If you do proceed with sinus lift in unhealthy sinus membrane, then patient will end up with lots of swelling and headache on their frontal sinus, even sphenoid sinus, ethmoidal sinus will be all clogged up when you see the CT scan, and absolutely bilateral sinus will be completely blocked because you're putting foreign material to the sinus, and that will block the natural ostium. Sinus needs to drain. If it doesn't drain, then you will have a complication. In fact, it is okay to perforate the sinus. Perforation is not a big deal. But if you perforate the sinus and the graft material goes into the sinus and blocks the natural ostium, that's when you have problem. So this patient was seen by a colleague, and patient couldn't open his eyes. So when I went to my colleague's practice, I had to do cardwell lock procedure to relieve the pressure in the sinus. And as you can see in this video, we are draining all the mucus out of sinus because previously blind technique has been performed, and he unfortunately blocked the ostium, and patient was not able to sleep for more than 1 week. So it's not a good idea to do a blind technique, and we have to be very careful not to block the natural ostium. So I think CT scan is mandatory prior to doing any sinus lift. And 4 things that I look out prior to doing sinus lift is making sure there's no water fluid level, which is a sign of acute sinus infection. And also, I want to make sure the ostium is open. If ostium is open, patient will do fine. Even if even if you perforate the sinus and the bone graft goes into the sinus, if the ostium is big enough, it will drain and it will come out through the nostril. But even if you don't perforate the sinus and everything goes well, if the ostium is blocked and the sinus membrane is not healthy, patient will develop symptom. So this patency of ostium is by far the most critical aspect, and thickness of membrane should be evaluated. As I mentioned earlier, thicker the membrane is not a good sign. It's a sign of chronic sinusitis, and I recommend to abort the procedure. And also the location of this infraorbital artery, it is a good indicator for choosing which techniques to use. Howard, am I boring you too much?
No, this is just amazing, and you're explaining it so well. So even if they're just listening to sound only on iTunes, they're still picking this up. This is outstanding. Just keep going. I could listen to you all day long.
Wonderful. Thank you. So let me talk to you a little bit about some clinical cases, some common complications that I've seen. And for example, this case was done by my good friend, and as you can see, patient developed sinusitis 1 week after a blind technique. And you can see the graft material all over the sinus, and the sinus is completely radio opaque with some kind of fluid. And this is when we go back and we remove the implant and we suction out all the granulational tissue and mucus and so on. So I asked my colleague to look at the preoperative CT scan on your right, you can see that on preoperative CT scan prior to doing a sinus lift, ostium is blocked. There is no opening to middle meatus, and ostium is completely blocked. And also you see that sinus membrane is very, very thick. And as I mentioned before, sinus is all about the natural ostium. If ostium is open, you will have a great result. In this case, blind technique was performed, and the thickness of membrane was not visualized, and it led to complication. So this is as an example of a CT scan that shows that this patient does not have a healthy sinus, and any kind of sinus lift should be contraindicated. And this is example of healthy sinus on your left and unhealthy sinus on your right. So you want to see a big opening, as you can see in this picture in my mouse. I don't know if you can see my mouse cursor, but this is an example of very nice sinus opening. Another important factor to note is presence of mucocele or a polyp. It is very commonly seen, especially in northeastern part of our country, where the temperature is very cold. I see a lot of mucocele and polyp inside patient's sinus. In this case, patient had a very, very large mucocele, as you can see in my outline with the white drawing. And the doctor did not take the CT scan, did not notice the mucocele. How do you know when you have a mucocele when you are doing surgery? When you are trying to lift the sinus, you can feel a lot of resistance. It almost feels like a balloon filled with fluid. And when you push it, the membrane comes back. And when patients breathe, the membrane does not move up and down. So that's a good example of mucocele. We have to make sure the mucocele is at least 22 millimeter away from osteomeatal complex, ostium. If it's closer than 22 millimeter, then study shows that there is a lot of complication. This is an example of a polyp inside the sinus. As a dentist, I think doing a sinus lift, we have to be very careful, because if patient develops a symptom after a sinus lift, medical legally, you have to be able to defend yourself. And if patient has polyp or mucocele, you want to identify, inform the patient, and also indication and contraindication should be discussed, and the risk and benefit should be discussed prior to performing, because last thing you want to have is you do a sinus lift, patient develops symptom, they go to ENT, and ENT says, "Whoa, I see this polyp around your dental implant," and you don't want to be blamed, especially not in the United States, where we have more lawyers than dentists.
More like that. More in.
So,
Yes. Yeah. There you go. Yeah.
So this is during my teaching program. I'm teaching a doctor how to extract mucocele. So we typically, when we have a mucocele, what we like to do is we want to aspirate the mucocele. We want to shrink it so that it's less than 22 millimeter away from osteomeatal complex. Now, I used to go in there and remove the whole mucocele, but I find that they return anyway. So nowadays, I just shrink them, and you will see a clear, not a clear, but yellow liquid come out from the sinus.
So what is a mucocele?
And this is example of a small arteriole when performing lateral window. And this actually, you can pretty much ignore this type of bleeding, because it will stop spontaneously, especially if you use cold saline, because body tends to vasoconstrict when we have cold temperature. However, sometimes the artery is so big that it will shoot out all the way to your to you. So you have to be very careful wearing eye protection, and you have to be very careful not to have blood come and invade your personal parts. So as you can see, sometimes the bleeding is very severe from the lateral window, and that is one of the reasons why I prefer to do Crestal window rather than lateral window technique. So this type of bleeding, we can use electrocautery to stop the bleeding. And a lot of times we see this type of bleeding shooting all the way to outside of the mouth, as you can see in this video taken with iPhone. Membrane perforation is one of very common complication. However, as I mentioned before, it is not a really bad complication. As long as patient has a good osteum, and this can be managed with collagen membrane and some suturing. So we develop nice instruments to be able to elevate the sinus membrane without perforation. This was a case where one of my referral attempted sinus lift for the first time. Unfortunately, there was a perforation, so I rescued the case by using a better instrument. And we will tack it with collagen membrane. But before we tack the collagen membrane, we want to suture the membrane. That way, the collagen membrane is not dislodged into the sinus. And membrane going into the sinus cavity is a very, very worst thing that can happen, because for sure, this membrane will block the natural osteum and you will have a complication. So you want to prevent the membrane going into the sinus. And how do I achieve that is I suture the sinus membrane with one of the walls so that we have a netting effect. And then I introduce collagen membrane. Certainly, you can use the tacks, bony tacks, to hold the membrane from moving into the sinus. But I don't like to re-enter the surgical site to remove the tack. So I just use the suturing technique to hold the membrane, and we will continue to elevate. Another common complication that I see all the time is people do blind technique and the membrane is torn and implant is introduced into the sinus, and I have to go there and remove the implant from inside of sinus. So we have to make sure we have a good stability, and also if the perforation is big enough, it's better to avoid putting implant into the sinus. So as I mentioned before, many people recommend lateral window when we have less than 5 millimeter, and we recommend Crestal window when we have more than 5 millimeter of bone. But unfortunately, this recommendation seems to make sense. However, it is incorrect. And this is a two-dimensional recommendation. I would like to present to you a better classification, my three-dimensional classification, where the width of the bone is more important than the height of the bone. So remember, the sinus is three-dimensional. So don't rely just on two-dimensional X-ray to choose which technique to do. If patient has wide bone and about 7 or 6 millimeter of height, there's no reason to do sinus lift. We can utilize wide and short implant, and it's going to be easier for you and easier for the patient. Now, when patient present with wide ridge, but only 1 or 2 millimeter of bone height, I recommend to do my technique called Crestal window technique, even though it has less than 5 millimeter. When the bone is wide, we can make window through the crest, and it does not become a blind technique. We can see everything. In fact, in extraction site, after extracting a molar, you always have class 2, because always the ridge is more than 16 millimeter buccal. So when you have extraction site, don't do socket graft. Do the sinus lift first and then place wide implant at the same time. And you can minimize number of surgeries to our patients. Now, class 3 will be a conventional Summers osteotome case, but instead of using mallet or hammer to your patient, try to use innovative birds. Nowadays there is a lot of companies out there, but this particular bird is one that I invented in 2006. It's in the market, it's in United States and all over the world. And I have a little stopper, and I have a bird that does not cut the cnidaria membrane. Now, can we eliminate lateral window completely? Unfortunately, answer is no. When we have a very narrow ridge, but very, very pneumatized sinus, we have to do lateral window because we cannot do crestal window due to the fact that the crestal window will be too small and in a sense become a blind technique, because I do not like to do a blind technique in my patients. So this is a mini study that I did in my patients, and I asked the patients, how much pain do you have first day, third day, and the seventh day? And obviously you can see that all three different techniques, short implants, crestal window technique, or blind technique, is not very painful. However, lateral window technique is a very invasive procedure post-operatively. If we have some time, I do want to show you some cases, especially pertaining to Class 2, my Crestal window technique. Now, Crestal window technique, as I mentioned before, is best for extraction site. Here, I just extracted 2 molars, and I am using small mushroom instrument and cobra instruments to elevate the membrane. On your right, you can see that this is not a blind technique, and we utilize wide implant to seal the socket, and by utilizing healing abutment, you get primary closure all the time. And instead of doing 3 surgeries, socket grafting, sinus lift procedure, and implant procedure, we combine all these 3 surgeries into one, and patient is very happy. And we can restore this case in less than 6 months. Can we do Crestal window technique on a heel ridge? And the answer is yes. Let me show you one more time how this technique is not a blind technique. You can see certainly from occlusal surface of a mirror that this membrane can be visualized, and you know you did not get a perforation. You know this membrane is healthy because it's moving as patient is breathing, and this is the best technique to utilize. And in fact, there is no flap. You don't even need to make an incision, and just simple sutures to close this case. Now, when patients come with a very wide ridge, in this case, patient has only 1 or 2 millimeter of initial bone height, and most people would think, I have to do lateral window. However, doing a lateral window in a patient with very, very wide ridge is very difficult to perform because it's very difficult to go all the way to the palatal wall. So it makes more sense to make window through the crest. As you can see, here I made 4 crestal window, and I am lifting through this osteotomy, buccal and lingually, and touching palatal wall is much easier through this approach compared to a lateral window technique. Once again, to do a lateral window technique, you have to open a bigger flap because you have to go all the way to your cheekbone, and retraction is difficult, visibility is difficult. Now, when you are doing a Crestal window technique, it's like doing occlusal composite. It's the easiest procedure that you will do. Compared to lateral window, you have a very difficult time visualizing and seeing, and approach is very, very difficult. So I recommend Crestal window technique, which is not a blind technique and relatively easy to do. There's no artery that you have to worry about because the artery is 16 millimeter on the buccal side from the crest. Because we're lifting the sinus from the crest, we don't have to worry about the artery. So take your time, lift the sinus, and place implant at the same time, but you have to choose the right implant design. You have to choose the implant that is wider at the crest versus the body of implant, because we don't want to dislodge this implant into the sinus cavity. So 19 implants has been placed, simple suture has been done, and patient was very happy. Now, the question is, how can we temporize this full mouth case when we are doing a full mouth sinus case like this? So how I temporize this case is I will utilize, in order to prevent this type of accident, because when patients wear denture, it will push the implant into the sinus, and we don't want that to happen. So I recommend to place some implants on the palate, and here I place 3 palatal implants, and I reline the denture so that patients can wear prosthesis, and this prosthesis is not touching on the occlusal surface, so my implants are fine. On the lower is opposing denture, so I will immediately load the lower with the permanent crown, and the upper has been temporized with the denture, and the flanges are cut off. But the most important thing is after 19 implants, the patient is able to wear something so that he can go to his daily life. So we developed a special implant called palatal implant as well. And thanks to these palatal implants, none of the permanent implant, as you can see in this panoramic X-ray, all permanent implants survive, even with only 1 millimeter of sinus fluid. So I recommend using this palatal implants. And right now we're doing clinical studies, and we're almost done to introduce this palatal implants into a USA market. Unfortunately, I have to tell you that in America, as an American, I have to tell you that we are behind. When we go to Europe or Asia, they are much advanced compared to us because our FDA approval process is very slow. Plus, we have too many lawyers, and a lot of doctors are very scared to try new things. Our biomedical science has been very slow in development. So these implants are available in Europe, but unfortunately not in America yet. Hopefully next year we'll have these implants available, and we can make the patient very happy, as you can see. Now, these palatal implants are wonderful because it gives a lot of solutions to patients who are diabetic. For example, this patient is uncontrolled diabetic. She came to see us. Unfortunately, she was not a good candidate to receive bilateral sinus and implant. So I chose alternative, which is a palatal implant, and patient is very happy because her denture is very stable, and she does not have to use the glue anymore. And this is how she takes it out, and we just put 4 locators on the palate because everybody have bone on the palate. We may not have enough bone on the crest, but everybody have bone on the palate. So this is another patient in my office in San Diego. Patient is 97-year-old, and he wanted to have bilateral sinus lift and implant. And unfortunately, I told him it's going to take more than 2 years. And he told me he doesn't have 2 years. So we chose the alternative, which is to use palatal implants to stabilize his prosthesis. And when patient has nerve very close, this is the mental nerve, and this is the inferior nerve, and we can avoid cutting inferior nerve by putting 3 palatal implants on the mandibular. I named these implants palatal implants, but certainly you can use it on the mandible as well. Only problem with this mini implants, I call this palatal implants once again, these super mini implants, only problem is that they are so stable, patient did not finish with the permanent implants that I placed. So sometimes giving good temporaries, very good temporary is not very good because we may end up losing our permanent case. Howard, are you doing okay there?
I'm doing fantastic. This is so amazing, Sam.
Howard, I want to show you a couple other research and development that we do, if you may permit me.
Please.
So my goal here is to find out how much morbidity there is in a specific procedure. So we do a lot of clinical studies in my institute, And the best way to do clinical study is split mouth design. So in this case, patient present with a very narrow ridge bilaterally in lower mandible, posterior mandible. And here I chose to do GBR using titanium mesh and ridge splitting on the other side. And I asked the patient, how much pain do you have after this procedure, right side versus left side? And I compare them. And also I measure the swelling. How much swelling does this patient have 1 day, 3 day, and 7 day afterwards? But Howard, how much pain do you think there is when we compare? Which one is more painful when we compare ridge splitting versus GBR procedure?
Tell me.
So, in fact, I did not know which one is more invasive. That's why I conducted a study. And I thought GBR is less invasive because ridge splitting involves cutting the bone and spreading the bone apart, which sounds very painful. But after this study, I found that actually ridge splitting induces less swelling and less pain to the patient. And split mouth design is the only clinical studies we can do to find out without too much variable, because everybody has different pain level, everybody responds differently to inflammation. So split mouth design is very, very valuable. And I was able to do a lot of split mouth design in my seminars where I take 10 students only to China, to Mexico, Costa Rica, and Chile. And we do this about 10 times a year, 10 students per session for 5 days. And we teach them how to do implants. At the same time, we do free implants in various universities in China, Mexico, Costa Rica, and in Chile. So I want to show you a little video about our course. And our next course is in China in March 30th to April 3rd. And here we teach lateral window technique, guided bone regeneration, gum grafting, implant placement, and bone block technique, Crestal sinus lift, as I mentioned, IV sedation, ridge splitting, and because I'm a periodontist, of course, gum grafting as well. And here you get to place your own implant, and the facility is amazing. As you can see in this video, we have CT scan, lasers, we have the latest technology including piezo surgery, guided surgery, and sterile surgical technique, as you can see.
Highly recommended. Lots of fun. Lots of sightseeing. It's a new experience. I recommend for everyone.
Hi, I'm Dr. Barbara Winokur from Albuquerque, New Mexico. This is my third live surgery course, but by far the best live surgery course I've taken. We're able to do many different types of procedures, both simple implants all the way up to connective tissue grafts and chin blocks, sinus lifts. You can also assist or observe, take photos and videos so you can learn on your own. I am definitely coming back for another round of live surgery.
This has been one of the most exciting adventures in dentistry in my whole life here in China, and this group of students was unbelievable. It was a real diverse group from all over, from all levels of experience, and I don't think any of them had a spare minute. It was a wonderful experience.
Hi, my name is JT, Dr. So, I'm from San Jose, California. This is my first time. This is the best hands-on course ever. This is my first, but this won't be my last. I placed a bunch of plans, bone grafting, CT grafts, everything, chin block. We're gonna do everything you have seen in the videos. So come here.
Hi, I'm Brad Matasevich. I work in Hawaii. It's my second time taking Stanley's course, which Mexico the first time, and now we're in China today. I highly recommend it if you want to do any implant dentistry at all. Every time you take this course, your confidence and your abilities will soar. I can't say enough about it. I take it again.
How you doing? My name is Cornelius Yan. I'm from New York City. I've been placing implants for about 6-7 years. I found out Sam Lee and I at DEI a couple years ago. I met up with Guy, such a great guy, good lecturer.
decided to hit up on his programs. Went to Mexico program, to Peru. Now I'm in China. And in China, you can see the surgical suite is absolutely phenomenal, great assistance, and we do everything from simple implants, bridge splitting, block grafting, bone grafting, a lot of soft tissue, a lot of sinus lift. Definitely recommend Sam Lee's program, IEDI for China, if you guys can come.
So this is a program that I want to invite our dental town colleagues. Learning how to do implants is like learning how to swim. Can we learn how to swim by watching videos or reading books? Answer is no. No matter how much book reading or lectures that you attend, unless you start to do surgeries hands-on on a live patient, you will never learn how to do it. Your confidence level will never achieve there. So we recommend to join our live surgical course. It's a very small class. We only accept 10 students per session. That way we have a quality control. Some doctors ask me, how many implants can I place in your program? I tell them, not going to place many implants. Why? Because we are all about quality. Even if you place one implant, I want you to do a perfect implant placement rather than putting 30, 40 implants. Anybody can throw in 30 or 40 implants if you are not going to do a perfect implant. In fact, Howard, I can tell you, I place more than 10,000 implants now in my short career, but every implant I place, it takes me a long time because I want to put that implant exactly on central fossa, exactly on where the prosthetic goes, and it is a very, very challenging procedure. Howard, may I kind of change the subject a little bit and then show you one of the exciting research I'm doing in my office?
Sam, can I just add one thing, one
Sure.
recommendation to you?
Sure.
If there are people who don't want to leave the country, there's a homeless shelter in Phoenix, and they only work on vets, and they got a permit from the Arizona State State Board of Dental Examiners that if a licensed dentist from America goes there from another state, they have a temporary license. So you should be doing a course at the CAS. That's the CASS. And who's my buddy? My gosh. Who's my buddy at CAS? Let me just real quick. Chris Volchek. But I wish you would talk to Chris Volchek because I just want these townies. I just want these dentists to learn and get it done. But sometimes people are afraid to go to a foreign country, or it just puts it out of reach of some people. In Phoenix, Arizona, they love Phoenix, Arizona. You should talk to Chris Volchek because he's got a state-of-the-art 9-chair facility, and you have all the legal protections of going to another country. He's got the attorney general, the state board. Everybody gives you your paperwork, so you're all legally good. How does that sound to you?
Wow, that's a wonderful, wonderful opportunity. California also passed a law where if it's for nonprofit, dentists are allowed to perform surgeries in California. So we've been preparing a free clinic in California, in San Diego, to be able to perform implant surgeries for underserved communities. Now, our academy have two missions. Of course, first mission is to educate dentists and develop better techniques and materials for implants, dentistry. Now, second goal is to provide free dentistry to underserved communities. So we'll be very interested in expanding our services to Arizona. But one thing that my lawyer and other doctors recommended is to keep the less invasive, much slam dunk cases in United States, because unfortunately we do have a lot of lawyers and people sue you for anything. For example, one of my patient, one of my doctors who share a story, she's an OBGYN in New York and she does cancer therapies, and she saved a patient's life. And the patient was so happy that his surgery went so well. And he basically told the doctor, doctor, thank you so much for saving my life, but I have to sue you because I need the money. So we have, unfortunately, our legal system is not very favorable to us. So I recommend doing simple cases in United States, and more challenging and advanced courses should be done overseas, where my doctors don't have any legal responsibilities after the course.
Sam, how do these listeners get more information? Because you got two websites. You have ce4dentist.com and you have samleedental.com. Where do they explain what those two different websites are, and which one would they go to get more information about your courses?
Sure. At ce4dentist.com, we have several videos, and we have a schedule of all the events. ce4dentist.com stands for Continuing Education for Dentists. So that's where all the dentists should go for continuing education information. Now, samleedental.com is my personal website, where we are doing some fundraising to develop the world's smallest X-ray. I would like to discuss world's smallest X-ray a little bit, if I may. So when I was at Harvard, one of the requirements was to do a research, and I wanted to do something that impacts our community very much. So this is our facility in San Diego, and I'm holding the world's smallest dental X-ray. So I thought, instead of using regular X-ray, as you can see, by decreasing the distance, if we can decrease the distance tenfold, we can decrease the radiation 100-fold, because it's reversely proportional to the second power, as you can see in my diagram. So if I can make the X-ray very small to the point that we put it inside the mouth, then we can reduce the radiation by more than 100-fold. And that was my hypothesis. However, by doing various tests and experiments in cadaver, we were surprised to find out that this technology can reduce radiation up to 5,000 times. And it's much easier to use, because you're not shooting outside the mouth. You are actually putting right against the tooth, and you are able to get image. So your assistant will never miss an image, because it's pointed right on the tooth that you want to diagnose. And it's portable. It only requires 4 watts. So it doesn't have to be plugged in. You can use just the battery power, and you can carry it in your pocket throughout your office. So you only need one X-ray in your office, and it's very cost effective. Only one X-ray will do all the tricks. And this will replace most CT scans, because this is the only technology that can give you 3D image using this technology. So we just got this patent approved in November of 2015. And of course, this thesis work that I've done at Harvard, I graduated with honors from my thesis committee. And we just got $20 million grant from the government to develop this X-ray into a market. So it's a very exciting X-ray, and I just wanted to give our townies heads up of what kind of technology we're bringing into a market. So this is an example of a cadaver study that we did. We made an incision in the thyroid, so we put the sensor in the thyroid, and we measure the radiation in different locations compared to regular X-ray, which gives 5 microgray. This technology is almost undetectable. It's about 500 times less in this experiment, and I'll be more than happy to post more detail in the townie in the future. Another studies that we are doing in our institute is finding a stem cell. So in the PRF right now is very hot in terms of using it as a growth factor, but we do not want to end at osteoinductive phase. We want to go into osteogenic phase, And we have this technique where we aspirate the stem cell from the tuberosity. Instead of going to the arm, instead of going to iliac crest, we go right on the tuberosity. We are very comfortable in this location, and we can draw lots of stem cell for our experiment. So this is another project that we are working on to be able to bring a better osteogenic potential, and we found lots of CD34 and 45 cells in this tuberosity blood. Quite exciting technology that we will have pretty soon to our colleagues.
You are an amazing man. I mean, you're a unicorn. You are just a freak. I can't believe you do all this stuff.
Thank you, Howard. I'll take that as a compliment.
Oh my God, it's a compliment. I've met so many dentists from everywhere, from A to Z, and you're at the top of the list, buddy. I mean, you have so many amazing, genius projects going on.
Well, it's because dentistry is fun. I have to tell you, dentistry is my hobby, and I can tell you, everybody who I met through my educational program, they are such a dedicated people towards our patient. Otherwise, you will not spend money and time for continuing education. Those of you who are dedicated to your patient will log into Dental Town, will come into continuing education, invest your money and time, and I have never seen anybody that are really a bad person who are dentists. And that's why it makes my job very, very interesting and very, very fun to do. And I think we are very blessed to have such a great profession, which is considered to be a hobby. And I like to get more involvement with the Dental Town. I would like to post more lecture series, and I would like to get more involved with the Dental Town in the future.
I wish you would put a course up on Dental Town. I mean, because you have so many courses on CE4Dentist.com. I think if you put a course or two on Dental Town, it would be great marketing and advertising for your website, CE4Dentist.com.
Absolutely, absolutely. I'll be more than honored to do that. And Howard, do you think I can show you one case? Just,
absolutely. Keep going. I'm not going to stop you for anything.
Let me kind of present this sinus lift case that I did in my office in Boston. So patient came into my practice, but unfortunately, many specialists do not believe in bone grafting yet. As you can see, patient presented with pneumatized sinus and very, very knife edge ridge. Here, we cannot place an implant. We need to have at least 8 to 10 millimeter of bony width in order to place an implant. But here, patient presented with 1 millimeter of thickness. So how can we place an implant? And patient has been denied by many, many specialists that she has seen. So when she came to my office, we did the lateral window. And lateral window is relatively easy procedure to do. And in fact, it's a very exciting procedure because you can see the membrane move up and down. And it's not a blind technique. And I enjoy doing lateral window very much. But building bone is more exciting. Here, I took FTVA with the titanium reinforced membrane, and we build bone with just a cadaver bone. No going to calvarium or hip or iliac crest, tibia. You don't need to do that. You just take a bottle. You just put a whole bunch of FTVA, and with the right suturing technique and tension-free closure, we can build bone in any dimension we want. Here, after 8 months, I remove the membrane. Boom, we have more than 12 millimeter bone buccolingually compared to preoperative case. So we can build bone in any dimension we want. Now, building height is limited in terms of building height, but building the width is 99% successful, at least in my private office. So here you can see that pre and post-operative CT scan, we can build bone so that we can place implant with enough bony width. So osteotomy has been placed, and we always try to put the implant in tripod position. And patient wanted to do implants on the lower mandibular ridge. Here you see very thin keratinized tissue, which means the ridge is also very, very knife edge. Making incision is very difficult in this type of cases because the ridge is so thin. Putting the blade right at the crest is very, very challenging. Here we open the flap and the bone is just like a knife. It is so thin that it is impossible to place implant at the same time. And we have to be very careful not to touch the mental nerve, because once you touch the mental nerve, as I mentioned, we have too many lawyers in the United States. We have to be very careful not to have numbness. Now, decodification is very important on the mandibular, especially because it's mostly cortical bone. Tension-free flap management is very important, especially the lingual side. Here, I'm using BIOS collagen and titanium reinforced membrane. Only location I did not add titanium reinforced membrane is where the mental nerve is. Now, internal matrix suture that we teach in our course is very, very crucial in achieving tension-free closure, and primary closure is a must. I don't believe in open membrane technique. We should always try to do tension-free primary closure. So this is 3 months later, 6 months later, 9 months later. You can see that the ridge is much, much wider than before. Only area that is thin is around the mental nerve. So this is time after removal, and you can see nice amount of ridge augmentation that has been done. When you compare with the before picture, it was less than a millimeter, but now we have more than 16 millimeter of buccolingual ridge. Now it can be a little bit confusing where to place the implant because the ridge is so wide. So using the surgical guide is very, very crucial because the ridge is very wide, the case becomes very tricky. You can place the implant too buccally and the case becomes a crossbite. So I recommend to use surgical guide so that you can orient very nicely when we have too much bone. So this is before and after, and you can see that the width of the bone we can grow very, very nicely. But building height is very challenging because of the pressure, occlusal pressure. Is very challenging to build bone vertically. Only time we can build bone is when you have a defect like this. When we have the mesial and the distal wall, then we can build the vertical defect. However, like in this case, patient had a flat ridge and the interocclusal space was already limited. Therefore, building height is not indicated. Plus, building height is clinically very technique sensitive as well. So here, instead of building height, we decided to do nerve repositioning. So we made a small window on the mandible and we just retract the inferior alveolar nerve very, very lightly so that we can place implants longer than 10 millimeter. Because this patient is very young, she's only in her 50s and we don't want her to have a short implant. The short implant by far is a good alternative. However, Felice and Esposito published a very nice randomized controlled trial. However, the longest data they have is 5 years. So what happens after 5 years? We don't have a good long-term study. So we wanted to put very long implant with the informed consent, and we decided to do a minimally invasive inferior alveolar nerve lateralization. So this is after implant placement and sinus lift and nerve lateralization. And I just wanted to conclude today's podcast by mentioning that doctors are forever students, and we should always seek to find better technique and don't be so much trapped in the dogma, because dogma is always changing with the new technology. And I recommend you guys to join our institute, especially the hands-on training that we do. As I mentioned before, we cannot learn how to do surgeries by listening to the lecture or by watching video. Because when I hear, I forget. And when I see, I remember. But when I do, I understand. Thank you very much, Howard, for inviting me to this wonderful opportunity.
Sam, you are so amazing. Can I ask one question?
Sure.
I'm starting to hear rumblings more and more from ENTs, rhinologists, that a lot of sinus issues going on are actually failed upper root canals. Have you seen anything like that? In that the tooth had a root canal, it's asymptomatic, the person's having all kinds of sinus issues for years, and that it's literally odontogenic tooth origin. Do you hear any of that?
I see that all the time. In fact, sinus is connected to our upper molars. Therefore, if there is any periapical lesion, patient will have thicker cnidaria membrane. So always we work together with ENT to rule out whether the sinus symptoms are coming from the molars or from the sinus itself. So it's very common that I refer to endodontists for root canal treatment prior to doing any kind of sinus surgery, especially when I detect very, very thickened cnidaria membrane.
Yes, that's. I think that's becoming more and more common to realize now that these sinus issues could be odontogenic origin. Sam, I just think, I mean, seriously, dude, I tip my hat to you. A double doctor, starting all these companies. That X-ray technology you're talking about is just, it's just world class. I mean, you're a visionary. You're just an amazing man. I would give anything for you to put any of your courses on Dental Town, just because I want to market and advertise this amazing man, Sam Lee, so everybody knows you're a household name, because everybody needs to be listening to you.
Thank you, Howard. Thank you, Howard, for a wonderful opportunity. And like I said, all the dentists, we are all wonderful people, and dedicating to continuing education is the best thing for our patients.
So you live on two corners of America, the nice, sunny Southwest San Diego and the upper, bitter, cold Boston. Do you try to spend all your winters in San Diego and your summers in Boston?
Unfortunately, I travel to New England every month to see patients. I practice in New England 1 week out of month, and I practice in 3 weeks in San Diego. But recently, with the grant that we got from New York State, we're planning another move to New York State.
Okay, well, don't freeze to death, because the world needs you around for a long, long time.
Thank you. Thank you, Howard.
All right.